Good afternoon, all. I am Dr. Chitrakshi Tewari from Lady Harding Medical College, and I'll be presenting on the topic effect of insulin therapy on body composition of children with newly diagnosed type 1 diabetes mellitus. Starting with type 1 diabetes, these children usually present with a lower BMI and weight at the time of diagnosis. This is because their body is in a catabolic state because of insulin deficiency. But as soon as we initiate insulin therapy, their weight begins to increase within as soon as 6 to 8 weeks. But the important thing to know is what what actually is happening inside their body. Are they gaining muscle? Are they gaining fat? Or both? Surprisingly, there are not much studies which have focused on body composition of children with type 1 diabetes, especially at the time of diagnosis. Most studies have focused on children with established type 1 diabetes who are already on long term insulin therapy, and they have shown to have a higher fat mass than their healthy peers. And there is a paucity of studies that have tracked body composition of children with type 1 DM over a longer period of time, especially after diagnosis. And when talking about body composition, BMI is one thing that often comes up. But we have to realize that BMI has its limitations. It cannot differentiate between fat mass and body fat and fat-free mass. Therefore, we need other methods of body composition analysis, and which is where our study comes into play. So, keeping that in mind, let's see the objectives of our study. The primary objective is to study the change in body composition of children with newly diagnosed type 1 diabetes with that following 10 to 12 weeks of standard insulin therapy. And the secondary objective is to compare the body composition of children with type 1 DM with age and gender matched healthy controls. Coming on to the methodology, our study is a hospital-based prospective cohort study conducted in KSCH Hospital for the study duration May 2023 to November 2024. And the patients were selected from pediatric ER, OPD, and diabetes clinic of our hospital. For the cases, we included children with newly diagnosed type 1 diabetes from 5 to 18 years of age after they were stabilized and once started on basal bolus insulin therapy. To ensure that we are only studying the impact of type 1 diabetes and insulin therapy, we excluded children with chronic illnesses, children with disabilities which could restrict any physical activity, and chronic infections like HIV and tuberculosis. For comparison, we recruited age and sex matched healthy controls, and these children were either visiting OPD for minor ailments or were siblings of the cases. For sample size calculation, we used a reference study by Davis et al., who assessed mean body fat percent change in children with type 1 DM after 6 weeks of therapy. And our final sample size that was decided was 42 children in each arm. Now let's see the study flow. We started with 42 children with newly diagnosed type 1 diabetes. Once they were stabilized and fitted in the inclusion criteria, we assessed their anthropometric parameters along with body composition parameters. And they were followed up after 10 to 12 weeks of standard insulin therapy, and these parameters were reassessed. And same number of healthy age and gender matched controls were assessed for similar parameters. Uh, Among the anthropometric parameters, we measured weight, height, tricep skin fold thickness, and waist circumference. For body composition, we used a method called bioelectrical impedance analysis, which is a simple, non-invasive tool which allows independent measurement of intracellular and extracellular water and can be used in non-ambulatory patients as well. Coming on to the outcome parameters, our primary outcome variable was change in percent fat mass in children with type 1 DM after 10 to 12 weeks of standard insulin therapy as compared from diagnosis. And the secondary outcome variables were anthropometric as well as body composition parameters. The anthropometric parameters included weight, height, and BMI Z-score along with tricep skin fold thickness. And the body composition parameters included body fat mass, percent fat mass, fat-free mass, and percent fat-free mass. These parameters were compared between cases at diagnosis and following 10 to 12 weeks of insulin therapy, and cases at both time points were compared with controls as well. The statistical analysis was done using Microsoft Excel and SPSS version, and the comparison between groups was done using unpaired student t-test and within groups using paired t-test. Now let us see what we found out. The mean age in both cases and controls was 8.95 years, and majority of children belonging to the 5 to 9 year age group. Now let's see what we saw at diagnosis. At diagnosis, we saw, as can be seen in the graph, the blue graph represents cases at diagnosis, and the green part, sorry, and the green part indicates controls. Initially, what we saw was that the children with type 1 DM had a lower weight Z score, BMI Z score, and triceps skin fold thickness as compared to controls. And among the body composition, the cases showed a reduced body fat mass and percent fat mass, as can be seen in comparison to the controls. Their fat-free mass, however, was similar to controls, while the percent fat-free mass was higher than the controls, indicating that insulin deficiency leads to a decrease in fat mass at diagnosis. But does insulin therapy change the picture? Let's find out. After 10 to 12 weeks of standard insulin therapy, cases, the children showed an increase in weight Z score, BMI Z score, as well as triceps skin fold thickness. Their fat mass also increased along with increase in percent fat mass. Interestingly, their fat-free mass also showed an increase, though the percent fat-free mass decreased, as can be seen in the figures. The percent fat-free mass decreased because there was a rapid increase in fat mass as compared to the fat-free mass. But the important thing is, to what extent did it increase? Did these children catch up to their healthy peers, or were they still lagging behind? So for this, we compared these children again with the controls. Now, when compared to the controls, these children showed similar weight, BMI, and triceps skin fold thickness as compared to controls. However, on assessing the body composition, we found out that children with type 1 diabetes at the second assessment were still lagging behind in fat mass. They still had a decreased fat mass and a decreased fat mass percent. Their fat-free mass showed no significant difference. However, the percent fat-free mass was higher, indicating that the fat mass was still lagging behind. So, connecting everything together, at diagnosis, insulin deficiency creates a marked catabolic state which disproportionately decreases fat stores. But insulin therapy restores these changes. So, it can be concluded that while 10 to 12 weeks of insulin therapy restores weight, full full normalization may take a longer time. These children still require longer time to catch up to their healthy peers. So it can be concluded that while 10 to 12 weeks of insulin therapy restores weight, these children do not fully attain body composition of their healthy counterparts. Further studies with longer follow-ups are needed to assess the further changes. And studies with longer follow-up would explore long-term effects of insulin therapy. And in conclusion, I would like to say that insulin is life-saving, but its effect on body composition are complex. By unraveling all these complexities, we can ensure that our children not just survive, but thrive.